Hello viewers, good day to all of you. So today we are moving to the leg region of the lower limb. So in the consecutive classes I will be discussing about the various compartments of the leg, of which in today's lecture I will be discussing about the anterior and the lateral compartment of the leg. So our learning objectives for today will be to understand the topography of the anterior and posterior compartments of the leg, so thereby its extent of these two compartments, then followed by the contents, which is the muscles which is present in these two compartments, then the respective vessels and the nerves which supply the anterior and the lateral compartment of the leg, and finally we will just have a short description about the applied aspects. Okay. Now, before going into the anterior and posterior compartment, let us try to understand how the structures are actually disposed in the leg. So here you are able to see the cross section or the transverse section taken at the level of the middle of the leg. So definitely it is below the knee region. Now the leg is also called as the crura. The other name for leg is actually the crura. So externally it is surrounded by the skin. Then deep to the skin you have the superficial fascia. So superficial fascia contains variable amount of fat, okay, and that too mainly in the posterior part and to some extent in the anterior lateral part. But medially what happens is there is no fat, there is also no muscles, it is completely subcutaneous. So you can feel the whole length of the shaft of the tibia on the medial compartment. Okay, so that is why none of the books describe about the medial compartment, because there are no muscles in the medial compartment, there is no artery or vessels on the medial surface of the shaft of the tibia. Only in the upper 1/3 you have the insertion of the gyropes, that is your gracilis, sartorius and the semitendinosus, and they are separated by a bursa. Beyond that it is completely subcutaneous, and the anterior border of the tibia is also very sharp and it is actually called as the shin. Okay. So now deep to the superficial fascia, and in the superficial fascia you are able to see some structures. So your cutaneous vessels, mainly the small saphenous vein and cutaneous nerves you can see. Same way here you can see the great saphenous vein and of course some cutaneous nerves which will pierce the superficial fascia and supply the skin. Then deep to that you are seeing here is the deep fascia, which is actually called as the fascia crurae. Okay, that is actually called as the fascia crurae, which is the deep fascia. Traced above the fascia crurae is actually continuous with the popliteal fascia behind, and above in the thigh you can call it, it will be continuous as the fascia lata of the thigh. It is continuation or continues as the fascia lata of the thigh. Now this deep fascia sends processes which is getting attached as intermuscular septum. You are able to see this is actually the anterior intermuscular septum, and that is the posterior intramuscular septum. Okay, anterior intramuscular septum and posterior intramuscular septum. With respect to the posterior compartment, the structures or the muscles are arranged in two layers, superficial and deep, and there is an intervening medial or intermediate septum which is present. Okay, but the whole posterior compartment thereby is divided into two strata. Okay. Now you know this is actually the posterior compartment which is present as superficial and deep. This is your anterior or extensor compartment. Between the anterior and posterior intramuscular septum, you have a small lateral compartment, or also called as the peroneal compartment. Okay, lateral compartment or peroneal compartment. So this is actually our extensor compartment, which is limited by the extensor surface or lateral surface of the tibia medially. Laterally by the extensor surface of shaft of fibula or the medial surface of shaft of fibula. Posteriorly you see the interosseous membrane which is extending between the tibia and fibula. The interosseous membrane is forming the posterior limit. Anteriorly it is limited by the deep fascia or the fascia cruri of the leg. Okay. So anteriorly the deep fascia, medially I told you the tibia and the anterior border of the tibia, and laterally the fibula and the anterior intermuscular septum. So within these limitations, these forms the boundaries of the anterior or extensor compartment of the leg. The contents are mainly four muscles, are called as the four extensor muscles. They are the tibialis anterior. From medial to lateral you see tibialis anterior. Extensor hallucis longus. Hallux is nothing but great toe, where thumb we call it as pollux. So that is why pollicis we tell. Here it is hallux. So extensor hallucis longus. Then you have the extensor digitorum longus for the lateral four toes. Then more laterally you have a small muscle which is actually called as the Peroneus tertius. The other name for Peroneus, some books they use as fibularis. Instead of Peroneus you can write it as fibularis. So four muscles: tibialis anterior, extensor hallucis longus, extensor digitorum longus, and Peroneus tertius. The nerve of the compartment will be the deep peroneal nerve, and artery is the anterior tibial artery. The artery of the compartment is the anterior tibial artery, and the nerve is the deep peroneal nerve. Now we will actually try to understand the origin, insertion, nerve supply and action of these four muscles one by one. So the first muscle which we are going to discuss is the tibialis anterior. So it is present in the anterior part of the tibia. That is why it is actually called as the tibialis anterior. It is a multipinnate muscle. So it's a very powerful muscle action. So mainly you know what is a multipinnate muscle. Abundance of the muscle fibers are packed within a limited area to increase the power of contraction. The origin of the tibialis anterior is from the extensor surface of the tibia and from the adjoining interosseous membrane. Okay, so from the lateral surface or extensor surface, upper 2/3 of tibia, and from the interosseous membrane it arises, and also from area adjacent to the tibiofibular joint, superior tibiofibular joint. The tendon passes downwards, and at the lower end of tibia it crosses medially, and it is getting inserted into the base of the first metatarsal bone. So this is your first metatarsal bone, you are able to see here, inserting into the first metatarsal and also to the medial cuneiform. Okay, medial, this is your talus bone, this is your navicular bone. Navicular bone articulates with the medial, intermediate and lateral cuneiforms. You have 3 cuneiforms, and more laterally you have the cuboid. So totally you have 1, 2, 3, 4 bones distally. Then you have the navicular 5, talus above you are able to see, and below the heel bone is the calcaneum. So totally there are 7 tarsal bones. So the tibialis anterior muscle, they passes medially and getting inserted into the base of the first metatarsal bone. And not only that, because of the powerful contraction and very powerful muscle, the lower end, actually the anterior border of the tibia is somewhat rounded. If you carefully examine the anterior border of the tibia, the rest of the border is very sharp and it is called as the shin, whereas the lower part is actually somewhat rounded. Okay, so getting inserted into the base of the first metatarsal and the medial cuneiform. Action, dorsiflexion here at the ankle joint. It actually dorsiflexes the ankle. Since it is attaching here, it is also responsible for maintaining the medial longitudinal arch of the foot. If you examine the foot, you will be able to see your medial border of the foot is somewhat arched. The lateral border is also arched, but you won't be able to appreciate that arch laterally because of the soft tissues present here. But medial border you can appreciate very well. Okay, so arches of the foot is a separate topic which I will be discussing in the following lectures. So it is a powerful dorsiflexor of the ankle joint and maintains the medial longitudinal arch, and also it is a inverter of the foot. Inversion takes place at the subtalar joint. So subtalar means below the talus. Okay, so below the ankle joint, subtalar joint, okay, it takes place. Okay, or mid-tarsal joint, subtalar and mid-tarsal joint. So mainly it is a inverter of foot, dorsiflexor of ankle joint, maintains the medial longitudinal arch. That is the action of the tibialis anterior muscle. The next muscle which we are going to describe is the extensor hallucis longus muscle. The extensor hallucis longus actually arises from the medial surface or the extensor surface of the fibula. It is a unipinnate muscle. From the lower 2/5 of the shaft of the fibula it arises, and also from the adjoining interosseous membrane, and its origin is medial to the extensor digitorum longus. Okay, so this is the area of origin of extensor digitorum longus. It is lying somewhat medially, its origin. Then what happens is it passes downwards deep to the retinacula. Here you are able to see, you will be able to see the superior and inferior extensor retinaculum. So the retinacula are actually again modifications of the deep fascia which is present around the foot. Okay, so again retinacula of the foot I will be discussing in the next lecture. Immediate lecture following this I will describe about the retinacula of the foot. The functions of the retinacula is actually to hold the tendons in its place, because it should prevent the bowstringing of the tendons during various movements of the foot, and because the tendons are changing its direction from the leg to the foot, so that is why there are retinacula which is present. So it passes deep to the superior and inferior extensor retinacula, all the muscles, even the tibialis anterior, this extensor hallucis longus, and inserted into the base of the distal phalanx of the great toe. Okay, that is the terminal phalanx of the great toe, and it will cross in the ankle part or in the lower part of the extensor compartment. It crosses from medial to lateral side. The tendon actually crosses the anterior tibial vessel and the nerve from lateral to the medial side, and then it is getting inserted into the distal phalanx of great toe. So the main action of extensor hallucis longus is dorsiflexus. Actually, it actually dorsiflexion of the foot. It helps in dorsiflexion and dorsiflexion of the great toe, and it plays around the metatarsal, first metatarsal, like a pulley, and thereby what happens is it stretches the plantar aponeurosis which is present on the sole of the foot. So when it stretches the plantar aponeurosis, so thereby what happens is it increases the concavity of the foot, especially the medial border of the foot. It increases the concavity of the foot. So that is the action of the extensor hallucis longus. So if you look the three muscles, why I have projected here, especially the extensor digitorum longus and extensor hallucis longus. And one more muscle which is going to arise, that is the Peroneus tertius muscle. They all actually take mainly origin from the fibula. Except the Tibialis anterior, these two muscles, the other muscle, they actually take origin from the fibula. So fibula is mainly for muscle attachments. It defies the law of ossification and it is not involved in weight bearing. So fibula is not taking part in weight bearing, only the weight is transmitted to the tibia. So we have seen about the tibialis anterior, then we have next discussed about the extensor hallucis longus. So as I told you, it increases the concavity of the medial longitudinal arch by playing over the metatarsal, first metatarsal. The next muscle you are able to see here is the extensor digitorum longus. So this is the extensor digitorum longus muscle, again which originates from the upper 3/4 of the medial surface or extensor surface of shaft of fibula and along the lateral condyle of the tibia, a small adjoining area on the lateral condyle. And here you have the intermuscular septum which is attaching here, which is separating your extensor compartment from the lateral or the peroneal compartment. Both are separated by intermuscular septum. So it originates also from that adjoining intermuscular septum. Then the tendon passes downwards deep to the superior and inferior extensor retinaculum and it divides into 4 tendons for the lateral 4 toes, second, third, fourth and fifth toes. It divides at the level of metatarsophalangeal joints and then it inserts via the dorsal digital expansion. It inserts via the dorsal digital expansion. So again it is a dorsiflexor of the ankle joint and also dorsiflexion of the lateral 4 toes. Okay, so dorsiflexion of the ankle as well as the dorsiflexion of the lateral 4 toes is brought about by this extensor digitorum longus muscle. So you are able to see this is actually the dorsal digital expansion. Hope you remember the dorsal digital expansion of the upper limb. We have discussed about the dorsal digital expansion. In the same way, here also you have the dorsal digital expansion which is formed by the tendon of the extensor digitorum longus and it is joined by the tendons of the extensor digitorum brevis for the second, third and fourth toe, not the medial most which is going to go to the great toe. Okay, so joins the extensor digitorum brevis. Extensor digitorum longus is joined by the extensor digitorum brevis to form the extensor expansion at the level of metacarpophalangeal joints. It forms a hood-like structure and here it also receives the insertion of the lumbricals and the interossei muscle. So from the sole of the foot, dorsally it is going to receive the insertion of the lumbricals and the interossei muscle. Then what happens is it forms a slip which divides into three. You have a central slip and two collateral slips. You are able to see one center and two collateral slips. The center slip actually gets inserted into the middle phalanx, base of the middle phalanx. The two collateral slips again unite distally and gets inserted into the base of the distal phalanx. So thereby what happens is, through the dorsal digital expansion, it is actually controlling the action of these extensor muscles which are able to see and the flexor muscles which are able to see on the on the sole of the foot. Okay. So antagonistic muscles. So both the antagonistic muscles, what happens is, thereby it creates a balance between these two group of muscles through the dorsal digital expansion. So because of that only, what happens is, flexion at one joint and extension at the interphalangeal joint is possible mainly through this dorsal digital expansion. So we'll go to the last muscle of the extensor compartment, which is actually called as the Peroneus tertius. So the Peroneus tertius muscle, here you are able to see, which actually arises from the lower part of the shaft of the fibula, medial surface or extensor surface of the shaft of the fibula. It is considered as a part of the extensor digitorum longus. Okay, so it is considered as the fifth tendon of the extensor digitorum longus, continuation of extensor digitorum longus. It is getting inserted into the dorsal surface of the fifth metatarsal bone. Okay, so getting inserted into the dorsal surface of the fifth metatarsal bone, dorsiflexion of ankle and a weak everter of foot. Peroneus longus and brevis are only strong everters of foot. This Peroneus tertius is actually a weak everter of foot. You are able to understand. So all the tendons, they pass mainly deep to the superior extensor retinaculum and the inferior extensor retinaculum. So previous slide you can see, you have the superior extensor retinaculum and then you have the inferior extensor retinaculum. The tibialis anterior actually pierces. It actually pierces, or you can tell it passes between the superficial and splitting of the superior extensor retinaculum, where the tibialis anterior has its own synovial sheath. Then this is your extensor hallucis longus passing deep to the superior and inferior extensor retinaculum. Then this is the synovial sheath for the inferior extensor retinaculum, deep to that the synovial sheath for the extensor digitorum longus tendon. So these two retinacula I will be discussing immediately in my next class. In the dorsum of foot, we will also discuss about these retinacula of the foot. So Peroneus tertius muscle, dorsiflexion at the ankle joint, and it is a weak everter of foot. So the artery of the extensor compartment is the anterior tibial artery, which is a branch of the popliteal artery. So the popliteal artery divides into anterior tibial and posterior tibial artery. So the anterior tibial artery actually, what happens is, pierces the tibialis posterior muscle and then enters the extensor compartment by a gap between the interosseous membrane, through a gap in the interosseous membrane. Then it descends in front of the interosseous membrane. It is lying immediately anterior or on top of the interosseous membrane, and finally it continues as the dorsalis pedis artery. Okay, so it is continuing as the dorsalis pedis artery and it is accompanied by the venae committens. So the deep veins mostly below the leg is in the form of venae committens. Venae committens means a pair of veins accompanying on either side of the artery is actually called as the venae committens. So posterior relation, I told you it is resting on the interosseous membrane, and here below it rests on the ankle joint and lower end of tibia. Anteriorly, it is covered by the muscles and the deep fascia. Then it will be covered by the superior and extensor retinaculum. Okay, by the superior extensor retinaculum, and it is crossed by the tendon of extensor hallucis longus from lateral side to the medial side. So anterior relations, extensor muscles, deep fascia, superior extensor retinaculum here, and lower part it is crossed by the tendon of extensor hallucis longus from the lateral side to the medial side. Medially you have the tibialis anterior, laterally you have the extensor digitorum longus and the peroneus tertius muscle. So these are the relations of the anterior tibial artery. You look at the nerve which is accompanying the artery laterally, the deep peroneal nerve. In the middle of the leg, the nerve comes to lie anteriorly, but again it goes or maintains lateral relation only. It does not cross the artery. Okay. So anterior tibial artery. Now you look at the branches of anterior tibial artery. So here you are able to see the branches are the posterior tibial recurrent and the anterior tibial recurrent, which takes part in the genicular anastomosis. Okay. So anterior tibial recurrent and posterior tibial recurrent takes part in the genicular anastomosis around the knee joint. Then muscular branches to the surrounding muscles. Then here lower part it is going to give medial malleolar and lateral malleolar artery, which takes part in the malleolar network. Medial malleolar artery will anastomose with the same medial malleolar branch of posterior tibial artery and medial plantar artery. So they will form a network, medial malleolar network. Lateral malleolar branch will anastomose with the perforating branch of posterior tibial artery and lateral arcuate or lateral tarsal artery. Lateral tarsal artery, perforating branch of the posterior tibial artery. They form along with this lateral malleolar branch the lateral malleolar network. So medial and lateral malleolar networks, again it is anastomosis around the ankle joint. So these are the branches of the posterior anterior tibial artery, that is the posterior tibial recurrent, anterior tibial recurrent, muscular branches, medial malleolar artery and the lateral malleolar artery. The nerve of the anterior compartment is the deep peroneal nerve. So actually the deep peroneal nerve, here you are able to see, it actually originates from the lateral compartment, the common peroneal nerve, which is related near to the head of the fibula. Then it divides into the superficial peroneal and the deep peroneal nerve. The deep peroneal nerve winds around the neck of the fibula. Okay, so it actually winds around the neck of the fibula. Then it pierces the intermuscular septum and enters the anterior compartment. It is also called as the nervi hesitans. That means it is hesitating to cross the artery. It is lateral to the artery. Then in the middle of the leg, it comes anterior to the artery as if it is going to cross, but it never crosses and maintains laterally only, maintains its laterality. So that is why it is actually called as the nervi hesitans. Okay. So as I told you, pierces the intermuscular septum and enters the anterior compartment. It is always lateral to the artery, never crosses it, and passes deep to the extensor retinaculum, and it is going to divide into medial and lateral terminal branches. It also supplies cutaneous to the first interdigital space on the dorsum of foot. A small area, it actually gives a cutaneous supply. Apart from that, it supplies all the muscles of the extensor compartment, all the 4 extensor muscles: tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius, and gives an articular branch to the ankle joint. So that is about the deep peroneal nerve. So here you are able to see the deep peroneal nerve. As I told you, it divides finally terminally into medial and lateral branches, and small area in the first interdigital space, it supplies the skin over this region. Anterior leg syndrome or compartment syndromes. So mostly what happens is there is a swelling in the anterior compartment of the leg, followed by pain in the anterior compartment. Okay, it is due to the accumulation of fluid in the anterior compartment, which occurs mainly due to exhaustion. Okay, so excessive accumulation, you are able to see here, the fluid tries to spread on all directions, but we have a thick deep fascia. So because it is not able to spread naturally, it compresses the muscles, the vessels, and the nerves. Okay, so pain, and the pain gets severe on dorsiflexion. If you try to dorsiflex, naturally these muscles try to contract, it is not able to contract, and because the fluid is actually exerting a pressure, putting pressure over these muscles. Okay, so pain and swelling due to exhaustion, prolonged standing, and all those things. Because of this, there will be diminished venous return. The venous return against the gravity has to be pumped. Effective venous return is not there. Then arterial pulse is also diminished. You won't be able to feel the pulse, especially in the dorsum of foot, the dorsalis pedis artery pulse. Peripheral arterial pulse, you won't be able to feel the pulse. Dorsalis pedis artery, which is a continuation of the anterior tibial artery. Then even there will be a loss of cutaneous sensation. So mainly it can be treated by incision along the medial and lateral side of the tibia. You make a vertical incision and drain the fluid. So you have to incise the superficial fascia as well as the deep fascia to drain the fluid. In certain cases, especially in athletes, you come across a shin splint. There is no swelling, but you have pain. You feel pain in the extensor compartment without the swelling. So that is because of the stress fracture of the tibia, which is most common in the athletes. Okay, so that is about the anterior leg syndrome. And about the deep peroneal nerve, we have already discussed with the sciatic nerve itself. Compression or injury to the deep peroneal nerve causes foot drop. So all the extensor muscles are paralyzed. Naturally, the flexor muscles are unopposed and the foot is plantar flexed. That is actually called as the foot drop. So with this, we have finished the anterior compartment of the leg. We will come to the lateral compartment. Nothing much, it is a very short compartment. The boundaries of the lateral compartment, you are able to see here the lateral compartment of the leg. It is mainly bounded by the shaft, lateral surface of shaft of fibula, anteriorly by the anterior intermuscular septum, posteriorly by the posterior intermuscular septum, and laterally by the deep fascia or the fascia cruri. So I told you medially the shaft of fibula, the deep fascia laterally, anterior intermuscular septum in the front, and posterior intermuscular septum. So the contents, mainly two muscles are there, Peroneus longus and Peroneus brevis. The nerve of the compartment is the superficial peroneal nerve, and the artery is the peroneal branch of posterior tibial artery. Okay, peroneal artery or peroneal branch of the posterior tibial artery is the artery of the compartment. So here you are able to see this is actually the Peroneus longus muscle, which takes origin again from the fibula. From the upper part of the muscle is bipinnate and lower part is actually a unipinnate muscle. So from the shaft of the fibula, 2/3 of the lateral surface and adjoining lateral condyle of the tibia, it arises. The tendon passes downwards behind the lateral malleolus in a groove. It passes in a groove behind the lateral malleolus and separated from the lateral malleolus by the tendon of the Peroneus Brevis muscle. The Peroneus Brevis is present between this tendon and this one. The tendon passes behind the lateral malleolus, as I told you, deep to the peroneal retinaculum. So there have the peroneal retinaculum, you have the superior and inferior peroneal retinaculum. Then it passes in a groove which is actually the groove of the trochlea, peroneal trochlea of the calcaneus. Laterally you will see a projection which is actually called as the peroneal trochlea. Trochlea means pulley, where the tendon of the muscle plays. So downwards and forwards. Then again it changes its direction and passes forwards and medially to get inserted into the base or the inner surface of the base of the first metatarsal and the cuneiform bone. So it is getting inserted into the first metatarsal and the adjacent medial cuneiform bone. So that is the tendon of the Peroneus longus muscle which you are seeing on the sole or the under surface of the foot. The action, it is a powerful avatar. Okay, fine. The next, and it is also responsible for maintaining the transverse arch. So here you are able to see the Peroneus longus. It is passing due to the superior and inferior peroneal retinacula. Superior and inferior peroneal retinacula. Here you have a bony projection of calcaneum laterally which is called as the peroneal trochlea. It will pass below the peroneal retinacula. Then it passes downwards, forwards and medially, getting attached to the base of first metatarsal under surface and the adjoining medial cuneiform bone. The next muscle you are able to see here is the Peroneus Brevis, arising here from the lower 2/3 of the lateral surface of the shaft of the fibula and adjoining intermuscular septum. The tendon passes along with the Peroneus longus, same way deep to the superior peroneal retinaculum and inserted into the base of the fifth metatarsal bone. So this does not goes the under surface, it just getting inserted into the base of fifth metatarsal bone. Both the muscles are supplied by the superficial peroneal nerve. So Peroneus longus muscle and Peroneus brevis you are able to see here. As I told you, they are powerful avatars. Raising the lateral border of the foot is called as the eversion of foot. Maintains the lateral longitudinal arch, responsible for maintaining the concavity of the lateral longitudinal arch. Since the Peroneus longus goes up till here, it is also responsible for maintaining the transverse arch. Your lateral border of the foot is arched anterior-posteriorly. Your medial border of the foot is also arched anterior-posteriorly. Your foot is also transversely convex above. So that transverse convexity is actually maintained by the Peroneus longus muscle. So that is the action of the peroneal muscles. Not only that, your Peroneus longus muscle on prolonged contraction can also bring about plantar flexion of the foot. Since it goes to the under surface, on prolonged contraction it might also aid in the plantar flexion. So the nerve here you are able to see of the peroneal compartment is the superficial peroneal nerve. It's also called as the musculocutaneous nerve of the lower limb. Like your musculocutaneous nerve, you have the upper limb. It is also called as musculocutaneous because it supplies these two muscles, and then in the lower part it pierces the deep fascia and becomes cutaneous to supply the skin over the lower lateral part of the leg. And then in the dorsum of foot it divides into medial and lateral branches terminal branches, and then mainly it supplies your dorsum of foot, the majority of the dorsum of foot. Okay, supplies the dorsum of cutaneous innervation of the dorsum of foot is by the superficial peroneal nerve after piercing the deep fascia. Okay, so that is about the peroneal compartment. So today we have actually discussed about the anterior compartment or extensor compartment, then the peroneal compartment or the lateral compartment. The anterior compartment muscle, they actually bring about the dorsiflexion. The lateral compartment is also called as the everters of foot. Peroneus longus and brevis bring about the eversion of the foot. So thank you very much for your patient listening.